Good afternoon, everyone. I'm Leah Binder. I am President and CEO of the Leapfrog Group. We're here today for a webinar on the Consolidated Appropriations Act as part of our series on the subject. And today we're going to be focused on mental health parity requirements. Happens that today is a very timely day for us to do this webinar. The Department of Labor just did a briefing for the public on some of the actions that they plan on taking around mental health parity and enforcement of the Consolidated Appropriations Act. And it was a dramatic webinar. You'll hear more about that today as we talk with our guests. Before I introduce them, let me just also say I want to thank our co-sponsors who've been working with us very closely to plan this series, which we believe is of urgent importance to employers. They are Health Transformation Alliance, ERISA Industry Committee, and National Alliance of Healthcare Purchaser Coalitions. I want to thank them all for joining us in this effort. As you know, employer health, EAP, and mental health benefits are all siloed within health plans and within the offerings of the typical employer benefits plan. This delineation has enabled gaps in access, wait times, and payment parity for mental health versus medical benefits. And today we're going to talk about the specific actions that we believe will be essential in complying with the CAA mental health parity requirements and how that might tie in to actions by the Department of Labor, which, as I said, we heard more about today. So here's some housekeeping items for you to bear in mind today during our webinar. If you have questions, please put them in the chat function. We'll get to as many as we can, time permitting, toward the end. At the end, attendees will receive a free digital toolkit. It'll have templates and tips that were developed by the Health Transformation Alliance and any links or information that come up during the conversation today. We'll have a 5-question survey at the end. We encourage you to participate in that so we can make sure that all of the webinars in this series truly meet your needs. The recording will be made available on the Leapfrog Group website, that's leapfroggroup.org, as well as the toolkit information. So here's our panelists for today. We have James Gelfand. He is the Executive Vice President of the ERISA Industry Committee. Lee Lewis, Chief Strategy Officer and GM Medical for Health Transformation Alliance. And Michael Thompson, President and CEO of the National Alliance of Healthcare Purchaser Coalitions. We're going to start with James Gelfand.
Thank you, Leah. And what I'm going to do here is I'm going to share my screen and I'm going to attempt to give Mental Health Parity 101 in fewer than 15 minutes. So an insanely complicated law that we've been trying to figure it out for 10 or so years here. But I think we can do it because we're going to do very abbreviated. Obviously, this is not going to be legal advice. This is just our effort to try to explain the very basics of it and how it's evolved and changed so that you can identify some of the changes that have taken place under the Consolidated Appropriations Act and how you as a plan sponsor or service provider may be looking to make changes to your own efforts in compliance. So we'll go through the basics and we'll talk about not just the evolution of the statute because it has been amended and changed a couple times, but also the evolution of the compliance regime, which we heard more about this morning. And this big report that was just issued talks about probably even the next stages of what the compliance regime will look like. We'll talk a little bit about what happens if you don't comply with mental health parity, because I feel like we leave that off too often, you know, or what, right? And then we'll look specifically at what was in the Consolidated Appropriations Act in December of 2020 and how does that change what you need to be thinking about as a plan sponsor or service provider. So to start with, on the very basic level, keep in mind that there is no requirement for a self-insured plan to offer mental health benefits, which I know sounds crazy, right? But there's not really a requirement for a self-insured plan to offer coverage for any specific type of benefits for the most part. There's a list of less than a dozen, right, that have been enshrined in federal law over the course of a very, very long time. But overall, there's a huge amount of autonomy that's exercised by employers. Now, the thing is, over time, employers have realized that we've got to cover mental health, that it's an integral part of a good benefit for our employees and keeping them healthy and active, et cetera. And so what the mental health parity requirement is if you offer coverage for mental health, then it has to be essentially on the same level, just as good as the coverage that's offered for medical and surgical benefits. And I may or may not be, trying to use a bunch of acronyms like M/S for medical surgical, M/B for mental and behavioral, but I'll try not to do that and avoid some of the gobbledygook. To start with, the initial law that was passed was really, really focused on dollars and like length of stay and very easily measurable and easily comparable limitations that might be included in a plan, right? So if you had a copay of $50 to see a specialist on the medical side, then you could not have a copay of $75 to see a specialist on the mental health side. And this is very easy. You could look at your plan and you can know immediately, is there a separate deductible that's different? Are there separate copays that are different? Are there separate lengths of stay or limitations that are easily quantifiable? That's what most of the legislative sort of negotiations were focused on back then over a decade ago. But over time, what does it mean to comply with mental health parity has ballooned and ballooned and ballooned, right? So even just 1 year after the bill passed, it went into the regulatory stage, and the regulators had to write rules to implement mental health parity. And they invented this idea of non-quantitative treatment limitations, right? So an NQTL for short is any kind of limitation on mental health benefits that isn't easily comparable apples to apples between the mental health side and the medical surgical side. One of my favorite examples to use here are placements of prescription drugs within a prescription drug formulary, right? So every prescription drug has its own price. The different tiers of the formulary have their own formulas that are used to determine how much the patient has to pay out of pocket versus how much the plan is going to pay. And the placement of various drugs on various tiers of that formulary can have a pretty intense effect on the out-of-pocket costs that a plan participant is going to have to face. But it's certainly far more complicated than saying, oh, well, we're just going to do $5 copay for everything, right? Or tier 1 is $5 and tier 5 is $500, right? It's way more complicated than that. And so a non-quantitative treatment limitation requires you to justify how you are comparing the treatment limitations across those two sides of the benefit, not necessarily by saying it's the same dollar amount, but maybe it's the same formula that we used. Maybe it's not the exact same quantitative limitation, but it's the same justifications that are used to implement certain medical management limitations. So, we'll talk more about that later, but just know that was a huge expansion of parity, and it wasn't in the statute, and it was created by the regulators the year after it passed. Later, the Affordable Care Act passed, which applied mental health parity requirements to more plans. It said that certain services that previously had just been considered mental or behavioral health would now be considered preventive services, where the patient can't be asked to pay anything at all. It also said that mental health and behavioral health are an essential health benefit. So not only does that mean that in the individual and in the small group market, they're going to have to cover it, but it means in the self-insured market, you can't have annual or lifetime limits on mental or behavioral health. So that was a pretty big change. I think that most of the plans and plan sponsors that are part of ERIC didn't have those kind of limits at the time, but those who did had to wipe them out. Now, fast forward 6 years later to the 21st Century Cures legislation. This was legislation that was almost exclusively focused on biomedical innovation, right? How can we get more drugs to market, more cures, et cetera? But there was a provision in there on mental health parity. And what it did was It stepped up in enforcement. It stepped up compliance. It ordered the agencies to do a better job of explaining how to comply and a better job of putting out more information for plan sponsors. And also it's issued a clarification for plan sponsors saying, when we talk about mental health, we are including eating disorders in there. So if you have limitations on eating disorders, and if that includes inpatient stays for an eating disorder, then that needs to be compared with limitations on the medical side. And then finally, in 2020, the Consolidated Appropriations Act, which included the No Surprises Act and a number of other healthcare and transparency provisions, further stepped up audits and compliance. It didn't change the rules for mental health parity, but it did change what the compliance regime is going to look like and what the agencies are going to do to enforce that regime. So let's talk about compliance a little bit. I think initially, the agencies were looking for those dollar limitations. Why is that copay different from that copay? Why are you allowed to stay for 60 days if you have a certain medical condition, but you're limiting stay at an alcohol cessation facility to only 30 days? And those kinds of quantitative treatment limitations. But most of those treatment limitations kind of went away. And if you look at the kinds of reports that have been issued annually by the Department of Labor about mental health parity compliance, you'll see that it's less and less of these quantitative limitations. And so enforcement moved to NQTLs and say, well, what are those apples to oranges comparisons for which we need to better understand how are you justifying the limitations on one side versus the other? I don't think that the agencies feel that this has been properly complied with yet. And that's really the justification behind the CAA language, because they're hoping that by implementing these new requirements for compliance, that it'll lead to less non-compliance with the underlying law. And we'll talk about what it is and what that means in a minute. But just to say, they're still on phase 2. And the idea is that the CAA provisions are supposed to be sort of the bookend on phase 2, so they can move on to phase 3. What do we expect for phase 3? Well, they talked about it a little bit today when the Department of Labor talked about compliance so far. It's going to focus less upon those numerical limitations and more upon what is the actual experience for the plan beneficiary. And when you've got a plan beneficiary who has a medical issue, and you've got a plan beneficiary who has a mental health issue, how are their experiences comparing? And so they're going to be looking at things that may not have been part of the purview of parity before, whether it be the strength of your provider network, whether it be the broadness and breadth of your coverage, whether it be medical management techniques and the kinds of supports that are available to the plan beneficiaries. But that's what we're expecting them to move into, and they're telegraphing it. They're not making it a secret at all. They're saying that's what's next, because ultimately they believe that the goal of mental health parity is for the experience of the plan beneficiaries to be streamlined across both sides of the plan. So talking a little bit about what happens if you fail to comply. I mean, under the current regime, they'll tell you there's something wrong with your plan. We received a report or a complaint from a beneficiary or from a provider. We audited your plan, et cetera. We found a problem, okay? What happens next is that the plan sponsor is supposed to work with their vendors to fix the problem, to eliminate the violation, which means you got to update the terms of your plan and change the benefits that are offered so that they're no longer discriminatory between mental and med-surg. But going a little bit further, you usually have to make some efforts to make right by those plan participants who were adversely affected, which may mean that you need to go back and reprocess claims from 1 year, 2 years, 3 years ago. You may need to pay for claims that you denied before. You may need to alert beneficiaries that they need to refile claims, et cetera. But either way, it's more than just fixing the problem going forward. There is a backwards looking aspect of this where you need to be able to say, well, we did figure out what the problem was, and we figured out who experienced the problem, and we attempted to make right by them. It's worth noting that Congress is currently considering legislation that would create another consequence for noncompliance. And that consequence would be civil monetary penalties, modeled after those penalties that are available under the Genetic Information Non-Discrimination Act. And so then if an employer was found to have a violation, they would still have to fix the terms of the plan. They would still have to make right by those beneficiaries, but they would also have to cut a big fat check to the federal government. So very important to follow that. That provision is probably pretty close to becoming law. Obviously, Eric and other employer groups are working to sort of try to change that to ensure that an employer gets due process before being assessed a fine. But you'll see in the recommendations that Department of Labor issued today for how to improve mental health parity compliance and to improve the patient experience, this was one of the things that they called for. They called for being able to impose those penalties. Looking at the requirements that were included in the Consolidated Appropriations Act, a couple of things that need to be noted. Number one, the plan sponsor needs to have on hand parity analysis for every single limitation on the mental and behavioral side of the plan. What does that mean? It means that if there is any limitation on the benefits that an individual can exercise under mental health or behavioral health, you need a document that specifically speaks to that limitation, explains what the limitation is, and explains how it compares across the mental health and the medical surgical side. So if it's a pure dollars to dollars limitation, that's not going to be hard to do, right? It's a 15-day stay. It's a $45 copay. If it is a non-quantitative treatment limitation, then you're probably going to need to delve into the methodology that was used, right? You're probably going to need to delve into the justifications for it. We're following the recommendations of the APA or of the National Lymphoma Society or et cetera. You need to include the rationale that was used. It can't be a generalization. Oh, this is the kinds of information that we use when we are developing NQTLs. It cannot be equations that say, oh, well, generally, we plug the benefit into this, and this is what comes out the other side of the equation. And it also can't be a document dump, like one giant document that this explains everything in our plan, which there's no way to actually find information about a specific limitation within the plan. DOL has begun auditing plans directly. Like I said, in previous iterations of the compliance regime, there really needed to be a complaint against the plan for DOL to start looking at it. But one of the consequences of the Consolidated Appropriations Act is that DOL now has to affirmatively go out and look at different plans, look at different vendors, et cetera. And what we were hearing up until this morning, and what has now been confirmed by the federal agencies, is that they are not satisfied with compliance. And they straight up said, compliance with mental health parity is not sufficient. Plan sponsors are not in compliance. They've rejected the analyses that plans have given to them. There have also been many, many plans that have said, oh, I don't have that information. That United Behavioral Health has that information for me. I counted on Magellan to hold that information. I counted on my TPA. Mercer has that information for me. And what DOL says is not good enough. That's not an excuse. They don't regulate those service providers most of the time. They regulate plan sponsors. And so the requirements say plan sponsors need to have that information. There have been many plans that have tried to just give them everything. Here's all the information about my plan. I'm sure that will meet the information requirement that DOL is giving to us. And DOL is saying, no, we don't have infinite man hours to spend on all these audits. We want the specific information that we're asking for. And they've also outlined more than once that when they're finding violations in plans, they're oftentimes finding that this different plans have the same violations. Why? Well, because they're hiring the same vendors to help them comply with mental health parity. And so increasingly, DOL is trying to interface directly with some of those vendors to try to figure out, well, why is this behavioral health vendor including this limitation, which then is filtering down, it's trickling down to all the different self-insured plans and it's filtering down into the individual and small group market. And they're going to be trying to see if they can take a more systemic approach in some instances, rather than playing whack-a-mole and going after all these individual plans. I mean, DOL could use every man-hour that's available to audit as many plans as they possibly can every single year. And it would be decades before they had gotten around to a significant portion of them. That's how many different plans there are. So they really do need to go to a higher level and try to find a way to sort of nip these problems in the bud, rather than waiting for them to percolate and grow, et cetera. A couple things that I would mention. Number one is that this did not change parity law, okay? You were already supposed to have a parity analysis conducted every time you had a limitation in your plan. And I think many plan sponsors assumed that their vendors had already done it and had it on hand and could just, send it over when they asked. And so it's been a bit of a rude awakening for many employers to say, oh, you mean you never did a parity analysis for this specific limitation? You mean this document that DOL tells me I have to hand in a week, you don't have it to give to me? That's been a rude awakening. It's also important, I think, to note that when a plan sponsor purchases services from a behavioral health vendor, they're usually getting an assurance that the product is in compliance with current law. But that assurance is not necessarily enforceable under the law. And so it's going to require a lot more due diligence from employers going forward to actually investigate and make sure that these limitations actually do meet the requirements under the law. DOL's position is that they have no sympathy for the employers whatsoever, and they are not at all bashful about saying this. They feel that we already should have had this information, we already should have been investigating it, and the new CAA requirements to possess the information that justifies the limitations in our own plans is not really a new responsibility, and therefore they will not give us any leeway on it. So, just my final things that I'll say about this, you got to remember that the buck stops with the employer. DOL doesn't regulate insurance companies, okay? DOL doesn't regulate specialty vendors that you hire to help you with your plan. And so they're looking to go after the people that they have leverage on, and that's us, that's the employers. It's also worth noting that it's been tried. People have tried to say, hey, it's not, my contract says that my vendor will ensure that I am in compliance with mental health parity. So take it up with the vendor. DOL has said, no, that's not going to happen. We're not going to do that. We're looking at you, kid. So for the purposes of the new compliance regime, a lot more hands-on, a lot less sort of delegation, and a lot more due diligence that's going to have to be done by the employers. So that's my attempt at a mental health parity 101 in 15 or so minutes. I'm happy to answer questions in the Q&A, but I want to hand back the screen share back to my friends at Leapfrog.
Thank you, James. That was masterful in getting that all into 15 minutes. I'm very impressed. We're not going to take questions at the end, but there is one question that came up that is so directly related to something you just talked about that I thought maybe we'll just take that one question for you, James. Do you have any, and we'll come back to, there is another question, but we'll come back to that at the end. Do you have any insight into the type of expertise that the Department of Labor is using to conduct these types of audits? Like, are they hiring an audit firm or consultant like Aon?
Yeah, I don't know the answer to that. I know that they certainly have a staff that heads up investigations and it focuses on that. And I know that they have been getting more money, they've been getting more funding, and they've been looking for more funding, and they're asking for more funding once again this morning. And then they may use that to outsource in some ways, but I don't know to what extent these particular audits have been conducted directly by DOL staff or by contractors that they've been hiring.
Okay, great. Thank you. All right, so our next speaker is Lee Lewis.
Hey, everyone. Within HVA, we have a behavioral health kind of strategy group that wherein we bring together a number of employers. And a month or so ago, one of our participants shared this incredible story. She said that she just got notice from one of her plan members, a spouse of one of their employees, had needed to get some therapy for their child. And the EAP wasn't really able to connect them to somebody who could specialize like that. They needed someone with more training. So they went on the medical carrier site and they pulled up all the listings of different providers. And she started to make phone calls through the listings. And the first phone number didn't work, and the second phone number didn't work, and the third one, it was just sort of a message. And it turns out they weren't taking new patients. And as she sort of worked her way through, she finally found one listing that said, Dr. So-and-so at this location does therapy for children, does pediatric therapy. She thought, well, that's probably going to be my best bet. It was the only one that was listed that had that kind of moniker. And so she drove to the location, hoping to be able to find someone to help her child. And when they went inside, they realized that the listing was inaccurate and that in fact it was a methadone clinic. And they turned right around and left. And at that point sort of escalated the challenge up to their leadership. And in my mind, this is one of the best examples that sort of illustrates what James just illustrated, or what James just explained to us about where parity is headed, and that's parity of experience. It's, are we delivering an equal experience in mental health for people who are seeking those types of services as with those who are not? The obvious sort of conclusion on that is, if we were looking for a cardiologist, we wouldn't have that problem. If we were looking for an orthopedic surgeon, wouldn't have that problem, or a dermatologist, or an endocrinologist for diabetes. In any of these situations, you know what you're getting, the listings work, and you're able to find the person in order to take care of yourself and your family. And within HTA, we do work with employers. We're owned by employers as a co-op, and focus on solving kind of the big problems. I'm not an attorney, but I'm a tactician. And so generally we get the kinds of problems and challenges like James has just illustrated for us, and we look at what are common sense, actionable solutions that we can put in place to begin the journey of sort of correcting this and finding our way to the other side of this. The big takeaway that I just got from hearing James was that if we were to ask the DOL today, in fact they were asked, effectively no one is in compliance. I'll say that again. Basically, according to the DOL, generally speaking, no employer is today in compliance. And if we accept for a moment that might be the case, then we will, from my perspective, I want to address this problem as if we're not in compliance and think of things that we might be able to do to get us there, or certainly to get us closer. And there are three that come to mind. First is that we need to know what are the scenarios and the attributes within our plan that matter as it relates to comparing medical and surgical to behavioral health. We need to know our data, and we need to know the gaps. Second, we need to protect the benefit. Almost in a perfect storm, right as we've been expanding and doing everything we can to really expand our benefits so that people can access mental health, that's exactly the moment in which bad actors have been attacking the mental health benefit and seeking to extract money and steal money from health plans. That in order to be able to continue to be very generous here, we want to be able to do so while protecting the benefit from those who would take advantage. And then finally, the third thing is to increase our access and benefit in order to close the gaps. So knowing the gaps, knowing our data, protecting the benefit, and then finally improving it so that we can close the gaps that exist. So first, knowing. The main question of basically saying, okay, well, what is it that I need to know, and how do I need to approach it? There's an organization called the Path Forward. I'll probably refer to them a couple of times. If you're working with Mike at the National Alliance, or if you have a local business group on health or others, The Path Forward is sort of a central nonprofit that's been supported by many organizations. They've done a really good job at streamlining exactly what, the big areas that we might need to know. And this has also been picked up by a couple of states. Washington and Rhode Island have started to sort of adopt this mentality. And the things you need to know, one is in-network versus out-of-network. If you look at the 15 major specialties, excluding psychiatry, what's our in-network benefit? Usually it's in excess of 95-something%. And then look at your in-network benefit for mental health. Is there a gap? Second thing you need to know is wait times. If I want to see a provider in one of the 15 specialties, is it approximately the same wait time to see an adequate, appropriate provider within behavioral health? The third is reimbursement discrimination. One great thing of the 16 major specialties, all of them, if you go see a specialist in any of these specialties, endocrinology, dermatology, etc., they will use a single code, a 99213 or a 99214 will be the code for the office visit. And that's the same for an oncologist as it is for an orthopedic surgeon. And it's the same also for psychiatry. And we can look to see, are we reimbursing differently the 99214 office visits of the 15 specialties versus the 99214 office visit of psychiatry? That's a relatively easy question for us to ask. That's the kind of the third gap. The fourth gap that we need to know is denial rates. Once we've gone through and looked at our NQTLs, we can see, okay, I'm applying the same scrutiny and prior authorization capability across all my claims. That may be the case. Is there a way to numerically validate that or to confirm it? Yes, there is. It's looking at what is the denial rate of how often are we denying claims when medical necessity has been brought up for mental health versus how often are we denying claims for the same reason on the other 15 specialties. And if we look and there's a massive gap there, that might be an example of something that is out of parity, out of compliance that we might want to address. Okay, so those are the 4 areas. And within the toolkit that you'll get at the end of this webinar, there is a PDF in there of called the Model Data Request Form. It's awesome. Get the PDF, attach it to an email, and send it to your account manager at your insurance carrier. And doesn't cost anything. You don't have to hire a bunch of people to do it. You can simply do it. It's a 10-page PDF. There's about 5 pages where they can fill in information. And on that, it will ask those 4 questions. And if the carrier responds to it, you will now have the answers to those 4 questions. You'll be able to know what your gaps are, if you have any, so that you can start to address them. And it's something that is that you can use. I mean, if anyone asks now, hey, do you know your data? You're supposed to, by the way. Now you can say, yeah, I do. I actually asked on the major areas, and I got a response. And now, now I have a great starting place. I know where I'm at. Then the second question is getting your data. I ask employers all the time within HTA, this has been a big push for us for the last couple of years, is every employer should have their data. And they say to me, Lee, of course I have my data. And I say, okay, really? Well, in your servers? And they're like, well, no, it's with a data warehouse vendor. And I'm like, okay, great. Well, then why don't you ask your data warehouse vendor to send you a data feed of all your data and see how easy it is to get it? And what we find out is that, in fact, because your data warehouse vendor has your data, it does not mean that you have your data. And so then they say, well, Lee, it's radioactive. I don't want that data to cause a breach or something like that. I get that. Some employers have the IT and security teams in place in order to be able to receive their data safely. If you do not, there are solutions that are available as well. We're using them right now so that you can get military-grade encryption software on a lockbox server so that you can request data and be able to receive your data into a server that you can't breach, and still be able to have IT and technical support so that you can run analyses, so that you can run the analysis yourself to see how you're doing with these gaps. without always having to go back and ask for help. You can automate it. You can check it every day if you want, if you have access to your data. Within the toolkit you get at the end of this webinar, there's information on how to do that and the different software vendors you can use in order to complete this. Also, feel free to reach out to me anytime by email or whatever, and we can help. Okay, second area, protect. Didn't realize this was as big a problem as it is. But over the last couple of years, as employers have become more generous in looking to fix parity, bad actors have been on the move, and they've been finding ways to absolutely ransack health plans at a moment of generosity and good faith, and take from them the resources that are there to support these plan members, further driving up costs and making it harder for us to succeed in the mission. There's a couple of things you can do to protect your plan as it relates to this area. One of them is a great tip, also came from one of our members. I love taking credit for other people's ideas, right? One of our members actually came up with this idea, but I'll take credit for it. And it was the idea was, hey, we know that these people are calling in, they're out-of-network providers, they're calling into the health plan, and they're saying, hey, in many cases, the ID card might even be stolen. And they're saying, hey, what is the benefit on this or that service? They're finding out what the benefit is and if there's benefits allowed. And then from there, they're waiving whatever the member would have to pay and just pumping in huge fees on different services that never occurred, labs that were never collected, and almost always being done, out of network as a way to take advantage of the plan. One simple way that one of our members found to correct this is they said, hey, look, equal across medical, surgical, and mental health, but if somebody calls in out of network without any member in sight and starts quizzing you on what the benefits are, have it be a policy not to answer those questions for out-of-network providers, and simply say, I can provide that information to the member. If the member's on the phone, I can provide all that information, but our policy is for out-of-network facilities, we don't provide that information. Thought it was a great idea as a way to protect those assets and protect the benefits so that it can be affordable for everybody for years to come. The second thing, if you really want a sort of a crack team of special investigations people to monitor your claims, there's an organization that we work with. They're called SmartLight. If you want to go and give them a call or reach out to them, awesome. They are doing an amazing job where they will get your claims data, and they all worked at carriers for decades within Special Investigations Unit, and they will find any sort of fraud or made-up claims that are existing on anywhere in your plan, mental health or medical surge. They'll find those and they'll be able to stop them. So we have 3 employers who are saving over $50,000 a month right now on these false claims, and they guarantee a 2x ROI. So it's a great opportunity. If you want to be introduced, there is a special discount through HDA if that is of interest to you. But it doesn't matter. It's a great program if something like that is of interest. There's one that you can call. The third area is closing the gaps.
Leah, I'm not trying to interrupt you, but no, not out of time, but I just want to say I want to make sure we have lots of time to get to all the questions we're getting that you're generating. So just kind of give you a 3-minute warning. How's that? 5 minutes?
Okay, sounds great. Okay, put me on the clock. All right. So the fixing access, three strategies that we can do to sort of close the gaps and increase the access. First thing you can do is manual patching. Basically, and most people don't even realize you can do something like this. Brilliant idea, came from one of my member owners. They happen to be located in New York City. They have a lot of employees in New York City. So what did they do? They called up NYU and the med school and said, hey, we know that you have a ton of therapists over there, none of whom are in network, and they're sort of not even kind of listing themselves. They're sort of staying under radar. They said, hey, look, we would love to have a direct arrangement with you. They signed a contract, and now there's like 20 or 30 additional therapists at NYU connected to med school that are available to all their employees. If that seems really scary, one great thing is within the next few months, there should be we're still finalizing now, but a free site that anybody can use that you can go onto the website, put in the amount that you're willing to pay, And then you can call a provider with whom you want to have a direct contract, like NYU, or maybe there's a university near you, and they can connect with you through that modality in order to be able to negotiate around pricing, in order to expand your in-network benefit. The second thing on this is many of our employers are saying, look, what do we do in regular medicine if we don't have enough access? For instance, there's not enough in-network anesthesiologists either, right? We've known this for years. There's not enough in-network ER doctors either. Well, we know there's not enough in-network mental health providers, so what do? Let's just pay out of network with an in-network benefit. We've had many of our employers do that in such a way as to be able to add in-network benefits just by paying an in-network benefit to a mental health provider, regardless of where they are. That's a very quick way to close that gap around out-of-network benefits, to close the reimbursement discrimination, and to reduce wait times. And then the last area is, if you really want to go sort of bold on this, our members said, hey, we want to add reinforcements to our network. We want them to be in network. We don't want to do it patchwork. We want it to be coast to coast. We ran a quick RFP and evaluated several vendors. We found one that has this, Lyra. Many of you may have heard of Lyra, but it's been like an amazing partner. They have 5,000 providers, all 50 states, everywhere, in person or virtual, including psychiatry, that are out of network with carriers, and that if an employer wants to, you can add that to be all additional in-network therapeutic access. So you can cut your wait times, improve your discrimination on in and out of network. It really closes a lot of those gaps. So information on all of this will be included in the resource guide. Plus, email me, call me anytime. Would love to help you out and introduce you to our brilliant members who are really the ones solving all this stuff. And I'll stop there.
Thank you, Lee. That was a huge amount of information that was extremely valuable. We do have a number of questions. We're gonna go to Mike before we get to them, but there is one point that was raised. There are a lot of other vendors in the fraud and abuse space. There are a lot of other vendors in all of the spaces that you've discussed. I just want to be clear, this is totally independent webinar, and we encourage you to look at all of the vendors in all of these spaces and create a really competitive market for all these vendors so that we are able to to give employers the very best possible benefits program. So let me turn to Mike Thompson.
Yeah, and I'll keep my remarks very short because I know you do want to get to the Q&A. Just a couple of observations. First of all, if after listening to James and listening to Lee, you're not paralyzed, I don't know if you've been listening to James and listening to Lee. The reality is the issues around parity are extraordinarily complex. And the fact is that what you're doing is comparing two independent organizations, even within organizations. So even if the mental health is managed within the health plan, they're siloed and they don't talk to each other. And if one moves, the other has to stay in lockstep or not. And this is a continuously evolving type analysis. And James talked about 3 NQTLs, and there are a slew of NQTLs. And it's very, very complex. And Lee talked about the reimbursement issues. Reimbursement has been one of those areas that the plans have very much resisted as being an NQTL. And the Department of Labor has made very clear that it is an NQTL. It affects access if you don't pay as well for mental health versus for whatever. One of the points I would reinforce is when you're asking the people whose responsibility is to be in compliance, which is your service providers, don't assume that what they give you can be trusted, because largely what they have done heretofore is they have interpreted no one intentionally doesn't comply with the law, and yet we know the DOL's interpretation of the law and the plans and the provider organization, behavioral health organization interpretation are two different interpretations. You want to look for independence in looking at parity compliance. You want somebody independent of the plan that doesn't have skin in the game to make an assessment on your behalf. And frankly, this is why I think accreditation for parity is important. The other point I would want to make is, a lot of what Lee talked about is the member experience, the access issue. The access issue, I think, for any of us that are in the benefits arena, know it's a serious problem. Frankly, everybody in the industry knows it's a serious problem. The plans know it, the behavioral health organizations know it. This is not a big secret, but it is the source of the enforcement requirements under parity. They're getting complaints about it too. And that's why they're not going to let up until we solve the access problem. And so we at the National Alliance are very much focused, Lee mentioned it earlier, on the path forward for mental health and substance use. We would have a problem if there was no parity. And we need to work on those problems, the access and quality problems in mental health. And that requires, frankly, assertiveness of plan sponsors to move towards action plans that measurably improve. We do that through the coalitions, through the path forward, and working with our partners like the APA and Meadows Health Policy Institute and others. I just would encourage you, we can't get it done unless you have our back. If you don't care, you're going to be subject to these type of oversight and these regulations over time. And yeah, there's ways to make it go away, which is just pay all out of network in network. But in the meantime, many of you are representing networks that don't exist. You're representing networks that the patient experiences they can't get access to if they're a new patient. They're calling the people in your booklets and they can't get in. And then the story, boy, you can't make up that story, Lee. I'll keep that one on my file. So anyways, I'll stop there. I could go on and on. This is an area we are highly focused on. Frankly, I think the enforcement on parity is not going to improve access. Purchasers can improve access by insisting, don't make this a paper chase. Make this a vendor management issue. Yes, you're going to have to do the paper chase because it's a requirement of the law, but use it as an opportunity to talk seriously about how do we improve access and quality of mental health services, whether it's through primary care or specialty care, moving forward.
Thank you, Mike. I think and as usual, I think you have a very powerful call to action. I mean, I think that's what the National Alliance is known for, is a call to action on a global sense of why this all matters to all of us. This will make a difference, not only for our companies and for businesses, but for our families. So I think it's great that you're out there leading the charge on behalf of employers. I also think this is a good example of why we need employer coalitions. If you're an employer trying to navigate this extremely ambiguous new set of regulations that seems to be coming out of nowhere, it feels like it's coming out of nowhere. It's not, but it feels like it is. Then it's a good time to be working with employers in your community to try to address it together and to be strategic about it together, and not one off on this one. Try to join together. So we have some really, really good questions. So let me try to recount as many of them as we can. I guess this one would probably be for James. How does a Tele behavioral health vendor contracted by a self-insured employer fit into the parity equation, especially if it offers ongoing care?
Yeah, I think that is a question for which DOL might have a different answer than your vendors might have. I think that traditionally, the way that plan sponsors have approached this sort of thing is to say, okay, we have a plan that's in compliance, and now we're adding something on top, right? And so when they're adding icing onto the cake and a cherry on top, we're not worried about making that stuff compliant. But increasingly, DOL is looking at that. And I know I didn't get to talk about everything that was in the DOL report this morning, including they gave 5 legislative recommendations to Congress for ways that they want Congress to change mental health parity laws to make compliance better. And one of them specifically dealt with telehealth. So there is an acknowledgement within the Biden administration that the way forward in many aspects is going to be virtual, right? And Lee talked some about the impossibility of filling out your network in certain regions just because they're the provider shortage problem, et cetera, and the creative solutions that people have approached. And obviously, virtual care has been probably number one there. But My prediction is that increasingly there will be scrutiny on these telehealth benefits, and if there is within the telehealth benefits any kind of difference between the benefit available when an individual is seeking care for mental and behavioral or substance abuse versus when they're seeking care for a boo-boo or a sneeze, then that's going to be a problem, and DOL will be pointing that out.
Thank you. And we will have a link in your toolkit that comes right after this webinar. There's going to be a link to that DOL report that literally just came out. We're hot off the press. Okay, another question. For employers with union relationships, do CAA mental health parity requirements take precedence over collective bargaining agreements? James, you probably are the right person for that one as well.
Yeah, I think I put in the chat, CAA didn't change the underlying mental health parity law, right? So whatever your plan was supposed to be doing to comply with mental health parity before CAA is the exact same thing that your plan's supposed to be doing today, right? The plan terms of the plan shouldn't be changing. What changes is your requirement to actually have documentation on hand. So your collective bargaining agreement shouldn't have any effect on that. You're just going to have to get that data and have it available.
Okay. I think this question is probably for Lee. How do you protect members from balance billing if you allow in-network benefits without a network providers?
That's right. Generally, when similar to with anesthesia and emergency room, radiology and pathology, where there's a lot of out-of-network activity and plan sponsors most have just made the determination to pay them with an in-network benefit, you generally will pay them what's generally considered a fair, reasonable price. And then if they push back, rather than balance billing to the member, most health plans will simply pay up to sort of that negotiated rate. In some cases, if it's just, say, for an office visit, they'll pay at the price that's billed. So there's different methodologies to use there, and they almost all require some give and take in terms of finding a reasonable price. But the member copay might always be the same, right? If it's an in-network, the member share is going to be less.
So it sounds like there's some real risk of increased costs for employers.
There is. There's significant risk of increased cost. The good news is that the big costs that occur are, that's surgeries, major diagnoses, cancers, kidney failures, heart attacks, strokes, etc. What we're talking about here is $200 for a therapy session or something like that. It generally, in terms of magnitude, it's not like we're tripling the number of surgeries that are occurring. We're increasing the number of office visits.
Okay, another question. Does this only affect self-insured plans? I believe fully insured plans are the responsibility of the insurance provider. Does this apply to employer EAPs and carved out pharmacy? James or Lee? James?
James.
I'll speak to the fact that it most certainly applies both to self-insured plans and fully insured plans. It doesn't apply to a benefit that is not a health plan or a group health plan, right? So your EAP probably is not going to be considered that. Now, carving out your pharmacy and making that a separate benefit, that's one that I can't speak to. I know that generally DOL is looking at pharmacy as part of their investigation into parity. So I think generally that would be included, but there may be some very creative ways that certain vendors have tried to find to get out of that.
So an employer offering who's fully insured, offering, let's say, Aetna as their carrier, they are still where the buck stops. The employer. So
for a fully insured product, you're just a customer, right? You're not designing this plan. You're not setting the terms of this plan. So as a customer, you're not going to be necessarily responsible in the same way that you would be if you were a self-insured employer. Your vendor is going to be responsible. Now, obviously, there could be some findings of negligence, or finding that you purposely persuaded a vendor to change their plan to discriminate against somebody, but it's very unlikely. I think that for the most part, the biggest risks here are for those individual plans that are self-insured.
Okay. there's a request to draw distinctions between services provided under EAP versus medical plan. Is there, what's the distinction? Can we just clarify that?
Yeah, I mean, an EAP is a supplement, right? Your EAP is an add-on, and generally the EAP might be available to individuals who work for you that aren't even enrolled in your benefits plan. Then again, the benefits under an EAP often aren't that good, right? Like they're going to tell you you can get 3 free mental health visits, but it's going to take you 8 weeks before you're going to see the provider for the first time. So an EAP is not a replacement for a mental health benefit. Plus, and furthermore, it's going to be, I have a very hard time imagining any of the employers that I work with saying, oh yeah, our mental health benefit in our actual benefit is not good enough, but we've got an EAP that's supplementing it, so therefore, we're fine. I don't think that's the way that anyone's trying to comply.
And Leah, I think this is a general rule, right? That a lot of times employers have offered supplemental access points, Leah, or somebody like that, right? Ginger, others. And you would say, well, because of that supplemental access point, they have solved the parity problem. Not necessarily, because a lot of times that isn't considered part of the medical plan. It's considered as a supplemental program or supplemented service, right? And if that underlying plan is not in compliance, you still might have a problem. So you'd have to make the argument that it is part of it, but then you have to evaluate all the, one of the challenges when you carve things out is your vendors don't talk to each other. No way. They don't know what they do versus what they do and all that stuff, unless they have super liberal on every and everything they do. How do you know that it's equal to what happens or no worse than what happens on the medical side? It's so complex. So it's not that easy to dodge the ball of parity by just give it to somebody else. You really need the plans, the underlying plans that you rely on to get their act together on those issues. And again, you can comply with parity without providing adequate access. But parity does have these very strong rules, and CAA has raised the bar on what you have to provide to support them.
Okay, I'm looking at the time. Just want to make, okay. I'm looking at the time. We do have one more question from earlier. We have 2 minutes to answer it. It was specifically addressed toward James, but of course anyone else can add to it. Given the statutory evolution that you brilliantly and succinctly described, would there be any difference in the specific services that patients and their families might have experienced? For example, it seems there was some sort of addition at some point of a mental health patient-oriented or agreed upon action plan that was introduced with or for licensed mental health providers at some point, and it required a signed agreement between the licensed mental health provider and the patient. That, I'm afraid, that is so far beyond my pay grade to understand that question, but maybe you do.
I also see Mike nodding, so I don't know if you want to take a crack at it before I do.
I'll take, I mean, this is such a great question because, right? So, the provider, the service provider has come up with an approach where the doctor, the mental health provider and the patient work collaboratively on a joint work plan to get better. All very well intentioned and maybe terribly effective. Well, is that the same thing you do on the medical side? And is that somehow creating a barrier to yada yada? That's how this gets really tricky. And of course, I think what the plans have tended to do when they've done their own evaluation is trying to lean towards logic, right? No, well, that shouldn't get affected. Who says? It might be a parity violation because you don't require a similar thing on the medical side, unless you do.
I see. Yeah. Okay.
And
one note is,
and Mike,
everyone,
I would.
Oh, go ahead, James.
I was going to say, I think that what they'd be looking at in that case would be less sort of what was decided under that action plan, and more they would be looking at what are the circumstances in which you are creating these kinds of plans.
Why are you required to do an
action
action plan to get benefits, right? Do you have to do an action plan on the medical side to get benefits? Again, it's very complex.
Okay, it sounds like we've got some more to learn, and many of us are going to have to learn it the hard way, sadly, because a lot is still out there, a lot of ambiguity still. So I want to just in our last 1 minute tell you that look on the chat. You will see a link to our toolkit, a link to that Department of Labor report published today. It is very important for employers to take a look at that. And then finally, a survey that helps us to make sure these webinars are better and better and useful as possible to everyone. So I want to thank all of my guests, Mike Thompson from the National Alliance of Healthcare Purchaser Coalitions, James Gelfand from ERISA Industry Committee, and Lee Lewis from the Health Transformation Alliance. You've been just fantastic, and you've given us such an incredible amount of information in a very short time. And I think it's very important, and if not urgent, for employers to pay attention to this. There are lots of compliance issues coming down the road, and lots of change ahead. So let's all work together and make sure we do it as well as we can, and to the benefit not just of businesses, but for the American public. So I'm from the Leapfrog Group. I'm Leah Binder, and I thank you for joining us.